My name is Charles Facelis. I'm the Assistant Chief of Medicine and the Program Director at the VA Medical Center in Washington, D.C. and Associate Professor at the George Washington University School of Medicine. I will be doing rheumatology with you. The first part of this will be the evaluation of a patient with arthritis and rheumatic disease, and this involves a systematic approach. So all the patients that we're presented with on the boards you have to answer four basic questions before you could say what the reasonable diagnosis is and the reasonable plan of workup and treatment. The four questions involve: what is the distribution of the joint swelling or the joint involvement? The second one is it acute or chronic? Did this occur right, the last couple of days, or is this something that has been going on for a long time? That's something we always ask with any symptoms. And then, does this patient have any symptoms beyond the arthritis, like systemic symptoms, like other organ involvement, like rashes, like skin involvement, and so forth? And then number four is, does this patient have joint inflammation? So for you, the two most important questions that I see people have a problem with is the first one, the distribution of joint involvement, and the fourth one, people get questions wrong on about inflammation, joint inflammation, and we'll talk about that and clear all that up for you. So the first question is, what is the distribution? That's the most important question. You can't go any further without answering this question. If you don't answer this question, if your patient on the boards or in clinical practice doesn't fit one of these four categories, you can't go any further. You've got to go back, ask them more questions, do a better physical exam, and try to see where this patient fits. Because really, the distribution of joint involvement in rheumatic disease evaluation is the single most important thing that you could do in order to make a conclusion and make a diagnosis. Patients generally fit, and I say generally because there's always outliers, but generally fit 90% of the time, and for your purpose almost 100% of the time, they fit into one of four categories. The first category is the polyarticular symmetric. Polyarticular means more than 4 or 5 joints involved. Polyarticular. So it's not oligoarticular, just 2, 3 joints. It's polyarticular. At least 4, 5, 6 plus joints. Symmetric means, symmetry means that if my left wrist is involved, so is my right wrist. That's symmetry. That's symmetrical. My PIP joints are involved. In one hand, all my PIP joints are involved in the right hand too. My left knee is involved, so is my right knee. That's symmetry. Symmetry, both joints of the body are involved. That's symmetry. So polyarticular symmetric involvement is only seen in certain diseases. The classic disease is rheumatoid arthritis. Then the other disease, because the arthritis of this disease looks exactly like rheumatoid, is lupus. But lupus is a more systemic disease. So you're going to get a polyarticular symmetric arthritis in this patient with lupus, but then she's going to complain of skin rashes, she's going to complain of kidney problems, she's going to have lung involvement. So right away you see, even though we're just talking about arthritis, these patients are going to look a little bit different from one to the other. But the truth of the matter is that the arthritis in rheumatoid arthritis and in lupus clinically look the same. Lupus is non-erosive. It's a non-erosive arthritis, but when you look at it clinically, it looks exactly the same as rheumatoid arthritis. And then the third type of a polyarticular symmetric involvement that you could have is viral induced. The typical viruses that do that is hepatitis B. Sometimes it could occur before the jaundice, in the period before you have most of the symptomatology, and then some other viruses like Epstein-Barr virus. And then the one that they want you to know on the boards is parvovirus B19. Parvovirus B19, when it affects adults, it presents mostly with an arthropathy. It doesn't really cause the skin manifestations that you see in children. The slapped cheek and stuff like that, you don't see this in adults. So when I see a patient with polyarticular symmetric involvement, my mind goes to three things right away. Is it rheumatoid arthritis? Is it lupus? I look for more systemic things. Or is it viral? I'm going to start looking for Epstein-Barr infection, recent one, right? Or hepatitis B, or parvovirus B19. That's very important. The parvovirus B19, these are usually people that come into contact with little children, like a kindergarten teacher, right? Like somebody who's a teacher somewhere that comes into contact with a lot of kids. Then the second big group is the monoarticular. Monoarticular, because it's one joint, by definition, is asymmetric, right? It's one joint, only one joint. And then you have three diseases here. You have osteoarthritis, then you have a more acute disease, septic arthritis. The most common form of septic arthritis is GC. That's the most common one that we see. And then gout and pseudogout. Now it says here gout, but I want you to know all crystalline arthropathies. So gout and pseudogout, they all fit into the same group here. Monoarticular arthritis. Right away you should say, wait a second, but these diseases are totally different from one another. They are. So for example, osteoarthritis, right, presents as a more chronic disease, right? The person with osteoarthritis doesn't tell you, hey doc, I've had this for 2 days. I had this for months, years, and it's getting bad and worse, and that's why I came to you in the last couple of days. Patients with septic arthritis or gout, they wake up in the middle of the night, very painful joints. They call you the next day. They may call you in the middle of the night. Gouty arthritis, very painful. The guy says, I can't take it anymore. You know, cut my foot off, I can't take it. So different story there. But they all present with monoarticular arthritis. So when I see somebody, I hear a story about monoarticular arthritis, I think about these three diseases, and then my next question is it acute or chronic? Because if it's chronic, I'm going to think about osteoarthritis. If it's acute, I'm going to think about septic arthritis or gout. They look exactly the same. Then the fourth one is migratory arthritis. Now this is very interesting. People get the wrong definition here about migratory arthritis. Migratory means that the pain and inflammation migrates from joint to joint. When it goes from one joint to the other, the previous joint gets better. The next joint gets inflamed, and then it goes to another joint, and that joint gets better, and then the next one gets worse. So for example, the guy came in to me and had right knee swelling and erythema, and then came to me a week later, and now his shoulder is red and swollen. And I say to him, how about your knee? He says, oh, that's getting better. And then he came a couple of days later after that. Now his left wrist was involved, and his shoulder was getting better. That's migratory. It leaves one joint, goes to the other. Migratory arthritis is seen only in a couple of diseases, very important diseases. Lyme disease is very important, especially in areas where Lyme disease is endemic, like, you know, some parts of the East Coast. In areas of the Mid-Atlantic region, Lyme disease is endemic there too. Around Maryland, Virginia, very common. So look for it. A little kid comes in with migratory arthropathy, or an adult comes in with migratory arthropathy. Think about Lyme disease. Treat it really quick before you get even the results. GC, gonococcal arthritis, especially disseminated gonococcal arthritis, can present with migratory arthropathy. So right now, you know, you should say GC can present with migratory arthropathy. It could also present with monoarticular arthropathy, because that's part of the septic joint issue. It can present one way or the other. And then the third part of migratory arthropathy is rheumatic fever. We could see that. Migratory arthropathy with rheumatic fever, it's not that common in this country. But rheumatic fever, every time we say it's gone, then we get a new breakout somewhere. It's uncommon in this country. It's not the first things I would think about, but definitely think about it if you don't have Lyme disease or GC and you have migratory arthropathy. And then the last one is oligoarticular asymmetric. Oligoarticular, so just a few joints, less than 5, 6. And they are asymmetric. So this guy's left wrist is involved, his right shoulder is involved, his right knee. 3 joints, asymmetric, right? Asymmetric, the same joint is not involved in both sides of the body. And the answer is there's only 2 diseases here. The whole group of diseases called the spondyloarthropathies belong here in this group of patients. Ankylosing spondylitis, psoriatic arthritis, Reiter syndrome, enteropathic arthritis. These patients usually present with back pain, plus peripheral arthritis. What type of peripheral arthritis? Oligoarticular, asymmetric, usually involving the big joints. But they are young people, usually always have severe back pain. That is the typical spondyloarthropathy. Now, osteoarthritis could also sometimes present with oligoarticular asymmetric. So, for example, it's common for patients to come in and say, oh, my knee's killing me, doctor. I've had this for 2 years, and it's getting worse and worse and worse. And then you say, do you have any other pains? And they say, not that much, but I have a little bit on my fingers. And she shows you the 2 fingers on the left, the 4th and the 5th DIP on the left arm, right, on the left hand, and 2 joints there and 1 in the knee, oligoarticular asymmetric. So sometimes osteoarthritis could present in an oligoarticular asymmetric way, especially involving the small joints of the fingers, especially the distal interphalangeal joints. And we're going to talk about that later. So right now, you know a couple of things more. Osteoarthritis can present in one of 2 ways. It could present in a monoarticular fashion or a oligoarticular asymmetric fashion. Now think about these last 2 patients here, the spondyloarthropathies and OA. You're talking about different patients, right? These guys are young patients that have severe back pain, right? Inflammatory back pain, osteoarthritis. They may have some back pain, but that's not really their big deal, right? They have usually peripheral joint pain, and they're older individuals. So, but think about these 4 groups of distribution, because your patient has to fit into one of these 4 groups before you go any further. It has to be one of these 4 groups. You have to have a differential diagnosis based on the distribution of the joints. The second thing that we talked about, is it acute or chronic? So that's a basic question, right? So consider, I said, give an example, a patient presenting with monoarthritis. If the patient has symptoms for months to years, this is likely to be osteoarthritis, right? Because remember our differential of monoarthritis? It's osteoarthritis, septic arthritis, or crystal-induced arthropathy. On the other hand, if the monoarthritis occurred just a few days ago, the likely diagnosis will be crystal-induced arthropathy or septic arthritis. Totally different disease. So just the chronicity now, right, cuts your diagnosis right to 1 or 2 cases. The third one that's important in rheumatology, because some of these diseases, they have very interesting manifestations and systemic symptoms. That's what you look for, systemic symptoms. That's the third one, evidence of systemic symptoms. And think about the different diseases. For example, things like lupus are going to present as, you know, multiple organs involved. So the person with lupus is going to have symmetrical polyarthropathy, okay, but then she says, yeah, I have a rash in my face. You know, I'm short of breath. And then you do an exam and you find that she's got an effusion there. She may have central nervous system manifestation or confusion. She may have anemia and thrombocytopenia. She may have kidney involvement, lupus nephritis. Sjogren's is another interesting disease where these patients have exocrine involvement. So they tell you, yeah, I have symmetrical arthropathy, but you know, I have, you know, it's not bothering that much. What I really have is I have dry eyes, right? Dry eyes. I have like sand in my eyes all the time. And my cheeks are swollen up because they have parotid enlargement. And maybe I can't swallow well food because, they don't have any, the salivary glands are gone. So we didn't put Sjogren's syndrome in there in the differential diagnosis before in the polyarticular symmetric involvement, because usually when they give you Sjogren's syndrome, they tell you such evident characteristic things that you don't really have to remember, about the polyarticular symmetric involvement. That's usually a secondary thing. That's why when we were doing the differential diagnosis of polyarticular symmetric involvement, I only told you about lupus, rheumatoid arthritis, because in those cases sometimes those patients have minimal systemic symptoms. So you could get the wrong diagnosis versus the other. But Sjogren's, systemic sclerosis, those are usually things that really jump out at you, and the arthritis is the least of their problems. Systemic sclerosis, they have the taut skin, they have the Raynaud's phenomenon, and then there's the vasculitis syndromes like Wegener's when they have hemoptysis, sinusitis, right, and kidney involvement, versus osteoarthritis, where usually osteoarthritis is a non-systemic disease. It's a non-inflammatory, non-systemic disease, and the typical thing is it's either arthritis monoarticular or oligoarticular asymmetric, and you have no other systemic manifestations. The lab tests are always usually normal. So think about this, the systemic manifestations versus no systemic manifestations. That's also very important to look for. The fourth and last thing is it's very important because they ask us questions about this. So what's the big deal about inflammation? Why do we need to know about inflammation? Well, because there's certain diseases that are very inflammatory, and you could differentiate just based on that from other diseases that are non-inflammatory. Think about patients with rheumatoid arthritis or systemic lupus, right? They have inflammation in their joints, they're red, they're warm. Think about a case of osteoarthritis, where this is a non-inflammatory disease. So when you touch that joint, it's not red, it's not swollen, it doesn't have fluid in it too much, and so forth. Evidence of inflammation you should be able to get just from the history and the physical exam. The most important question to ask the patient is, do you have morning stiffness? If the patient has significant stiffness over 1 hour, that is an inflammatory disease. I don't know what disease it is, but it's an inflammatory disease. Patients with inflammation, their joints overnight, they kind of gel together. The inflammation kind of gels them together. And then in the morning time, they gel together because of immobilization. So in the morning time, they feel stiff. They can't open their arms. They can't move their legs. So what do? They start walking around. They take hot showers. They start exercising in the morning. The patient says to you, "Doc, yeah, I have to exercise 1 hour in the morning to get ready to, start moving around." Stiffness is not pain. These are two different things. The patient stiffness gets better as the day progresses because they're moving their arms, they're moving their feet. So they're loosening up their joints. As they move, as the day goes by, they feel better. When they wake up in the morning, they're worse. They're stiff again. People with joint pain because of erosions or because of osteoarthritis, their pain gets worse as the day goes by because now their joints are being used, so they're painful. That's a different story. Don't mix up joint stiffness with joint pain. Joint stiffness means inflammation, and it gets better with exercise, mobility, and as the day goes by, and it's worse in the morning time. On top of the joint stiffness, you'll see erythema and warmth when you examine the patient. You may look for effusions also, and then you could check the blood tests for erythrocyte sedimentation rate and C-reactive protein. So for example, a patient has rheumatoid arthritis or lupus, their SED rate and their C-reactive protein will always be elevated. A patient with osteoarthritis or with some kind of viral syndrome, right, arthritis from a viral syndrome, their SED rate and C-reactive protein are usually normal. So look for that. And then they may also tell us, well, can we show the inflammation from the aspirate? The answer is yeah. If you do an arthrocentesis, we don't always have to do it, but if we do it, we will see that this patient has evidence of inflammation on the white cells from the aspirate. They're usually anywhere from 5 to 50,000 white cells in the aspirate. That's inflammatory, non-infectious. So those are your four things. And we go further, not at all unless we've answered all four of those, about distribution, about chronicity, about systemic symptoms, about evidence of inflammation. So let's do a couple of examples here and make sure we understand this. A 62-year-old man presents with right knee pain. So if I say to you, this guy's had the knee pain now for 1 day. You look at the joint, it's red, it's warm, it's very painful. 1 day, red, warm, very painful, very stiff. What would be your conclusion? The answer would be that this patient has monoarticular arthritis, and the differential in this case would be either septic arthritis or crystal-induced arthropathy. What would be the next step in this case? Well, we'll find out later, but the next step in this case is do an arthrocentesis, make sure he doesn't have a septic joint and treat it, or prove that it's gout or pseudo-gout and treat that on the other hand. So that's a very important case. What if this guy says to you now, no, not, I've had this for 5 years. I, used to play football, right, a lot. And, I hear these, crunching sounds when I move my knee. But recently it's really hurting me. And you look at the joint, it's not red, it's not warm. You ask him, do you have any stiffness in the morning? He says, no, I don't have any stiffness. But as the day goes by, it hurts more and more when I walk around. So I'm, I usually stay on the chair watching TV. So then now your differential diagnosis totally changes, right? This is not septic arthritis. He doesn't have septic arthritis for years. He doesn't have gout for years. This is likely to be osteoarthritis. You look at you prove it with an x-ray and you treat accordingly. A 24-year-old woman presents with symmetric wrist, MCP, PIP swelling, and pain. So they told you, the wrists on both sides are involved, all the MCPs on both sides are involved, the PIPs on both sides are involved. So she has what is called polyarticular symmetric involvement. Polyarticular symmetric involvement. So what's your differential? Well, right away, there's only three things, right? Rheumatoid arthritis, lupus, right? And then we talked about the viral syndrome. So appropriate questions to pose to this patient and to do on the exam is to look for rashes or ask if she's had a rash, do a good lung exam, a good abdominal exam, start looking for kidney failure by checking creatinine, by checking protein in the urine, things like that. Start checking rheumatoid factor, anti-nuclear antibodies, and also making sure you don't have a viral infection like checking Epstein-Barr virus, hepatitis B, right, surface antigen, and parvovirus B19 antibodies. So this woman was a school teacher, and she had this, and her rheumatoid factor was negative. Her anti-nuclear antibodies were negative. She didn't have any evidence of systemic manifestations. Her Epstein-Barr virus was negative. It was actually the IgG was positive, but that's a long infection, right? That's an infection in the past. But her parvovirus, IgM, came back positive. IgM means recent infection. That's what she had. We gave her some nonsteroidal anti-inflammatories. 1 month later, she was as good as new. A 32-year-old man presents with right knee swelling. You have evaluated him a few days ago for right wrist swelling, and the pain has now resolved, meaning the right wrist swelling. So this guy has migratory arthropathy, and he actually came to us just a couple of days later. Now the knee was better, and now his left elbow was involved. And so this is migratory arthropathy. So our differential diagnosis here would be Lyme disease, right? Disseminated GC, right? And we said rheumatic fever. So this guy was a farmer, and he came into contact with ticks. He didn't think he got bit by a tick. He didn't remember a rash, but his titers for Lyme disease came back positive, and we treated him with amoxicillin for a couple of weeks, and it was well. So the right diagnosis here was likely Lyme disease. He didn't have anything to point towards, disseminated GC or anything else. So very important to say to these patients, you know, when you look at these patients, to make sure they fit into a specific group of patients that we talked about. This last patient here is a 29-year-old man who presents with right knee and left hip pain for many years. His other problem is chronic back pain and stiffness. So look at this, right knee, left hip pain, so that's oligoarticular asymmetric, and now he says, yeah, my back pain is very, you know, I have back pain and severe stiffness. And what I asked this guy is, this is a true case, I said, what do you mean by stiffness? And he said, oh, I have severe stiffness in the morning time. He said, I'm like a lead pipe, I can't move my back. And I said, what do you do? He said, I take a hot shower and I work out, you know, an hour and 15 minutes every day just to loosen up. That was typical of what he did. And of course, this guy had ankylosing spondylitis. So right away you get an idea, you know, from the age and the back stiffness, that this is an inflammatory process and it involves a young man. It's likely not to be osteoarthritis. Remember, our other differential diagnosis of oligoarticular asymmetric was osteoarthritis. 29-year-old people don't get osteoarthritis. And not only that, they don't have inflammatory back pain. This guy had inflammatory back pain. We did the x-ray of his lower back and his sacroiliac joints, and there was evidence of inflammation there. The bamboo spine was evident. He had typical ankylosing spondylitis. This concludes the evaluation of the patient with arthritis.